Good evening and welcome to the Ann Arbor District Library's AADL TV channel. Thanks for tuning in for tonight's presentation of Bright Nights with the University of Michigan and Michigan Medicine's Depression Center. In just a moment, Stephanie Salazar will introduce our guests. If you enjoy this program, don't forget to click like below and follow our channel for more AADL programming.
Thank you for joining us this evening for this evening's event where we'll be exploring structural racism and mental health in the community with clinical social workers Saima Khan and David Fulkerson, who both serve as co-leads for the Department of Psychiatry's Diversity, Equity, and Inclusion Committee. They will be providing an overview of the topic, and then we solicited some questions from online, and they'll be answering some community questions. For a little bit of background, Saima Khan received her Master of Social Work from the University of Michigan School of Social Work with a focus on interpersonal practice in children and youth and families in society. Saima completed an internship with the inpatient child psychiatric unit during her training. Since graduation, Saima has worked in many settings in the health system, including psychiatric emergency services, as well as the child and adult inpatient psychiatric units. Saima currently works on the pediatric consultation, Saima currently works on the pediatric consultation and liaison psychiatry service in Mott Children's Hospital. Her areas of interest include working with children with chronic mental illness, suicide assessment, safety planning, and helping families navigate complex care systems. Saima is also passionate about normalizing mental health within medical settings and providing educations to medical care teams around diagnosis, treatment, and community resources. She also holds a Master of Public Health from the University of Michigan School of Public Health. And David Fulkerson received his master's degree in social work from the University of Michigan with a focus on interpersonal practice and mental health. David completed a year-long internship at the University of Michigan Comprehensive Gender Services Program, where he provided mental health and case management services for transgender and gender nonconforming children and adults. David then completed 1 year as a postgraduate social work fellow in child and adolescent psychiatry, and now holds a staff position as a clinical social worker working with children, adolescents, and their families. David's clinical interests include working with children and adolescents in the LGBTQ community, anxiety disorders, depression, and working with both young children and adolescents who have experienced trauma. Thank you, Saima and David, for being here today.
Thank you, Stephanie.
Thank you, Stephanie. So just to get started on our presentation, we sort of conceptualized this as an arc of sort of looking at our community, and by community we mean Washtenaw County, and then describing kind of how our community looks in terms of mental health, and then going through some definitions, and then thinking of ways that we can affect change and also educate ourselves to affect positive change in our community. So this first slide you can see shows that there are some really positive things about our community. Washtenaw County is #1 in Michigan for health factors. Ann Arbor, the largest city in the county, is #1 in the United States as most educated city in America. We are #6 in cities that are secretly great for tech grads. I'm not sure how much of a secret that is. #3 is hottest housing market in the country, and #5 in green cities for families, and #1 in city for millennials. However, on the other side of that, we can see some negative aspects of our community. Washtenaw County ranked 80th out of 83 for income inequality. We have a racial gap of more than 38 to 40 points in student test scores. And we are the 8th most economically segregated city in the country. Washtenaw County is the #1 most expensive rental market in Michigan. And finally, we are at the bottom 8% for upward income mobility. So as you can see, there's quite a mixed story here in terms of this very brief and superficial look at our community. but it can tell us and inform us of things that we, of aspects that we need to work on. So a little bit of a closer look. We have two different communities in our county. Sugarbrook and nearby neighborhoods is in Ypsilanti, or near Ypsilanti. And then Scioto Township is essentially it's Ann Arbor Public Schools. It shares a lot of the city of Ann Arbor's amenities, but it is just outside of the city limits. And so just at a glance, you can see that the life expectancy on average in Scioto Township is 4 years longer than that in Sugarbrook, 83 to 79. Scioto Township, all children live above the poverty line, whereas in Sugarbrook, 37% of the children in that community live in poverty. 85% of third graders are reading proficient in Scioto Township, compared with 21% in Sugarbrook. And 4 in 5 adults over 25 hold a college degree in Scioto versus 1 in 7 in Sugarbrook. Scioto Township's unemployment rate is 6.6% versus 17% in Sugarbrook. And then this last bit of data does not reflect the most current presidential and general elections, but it shows 83% of registered voters in 2016 voted in the presidential election versus 46% of registered voters in Sugarbrook. And so before we get into kind of why or what to do with this information, we want to come up with or describe and define racism in a few different ways. So this is a definition that looks at 4 different levels of racism. Interpersonal at the top, the expression of racism between individuals that occurs when individuals interact and their private beliefs affect their interactions. So these are the things that people experience day to day. These are the things that are often seen if you're scrolling through Instagram or Facebook, people talking about their experiences or recording very negative interactions in the community. And then the next level is internalized racism, which is the set of private beliefs, prejudices, and ideas that individuals have about the superiority of whites and the inferiority of people of color. Among people of color, it manifests as internalized oppression. Among whites, it manifests as internalized racial superiority. So these are the aspects that we are core beliefs per se, and it can inform how we interpret interactions with others. It informs how we see ourselves in those interactions, and it informs how we see ourselves, period, in our community. Next, we have institutional racism, which is discriminatory treatment, unfair policies and practices, inequitable opportunities and impacts within organizations and institutions based on race that routinely produce racially inequitable outcomes for people of color and advantages for white people. Individuals within institutions take on the power of the institution when they reinforce racial inequities. And this institution, the institutional racism has a pretty broad range. It can be where you work. It can be the city government in the community that you live. It can be the healthcare system. It can be the education system, public schools, et cetera, all the way up to federal government. And then structural racism, a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways, in various, often reinforcing ways to perpetuate racial group inequality. It is racial bias among institutions and across society. It involves the cumulative and compounding effects of an array of societal factors, including the history, culture, ideology, and interactions of institutions and policies that systematically privilege white people and disadvantage people of color.
So to provide these definitions, I think we really wanted to set the stage for us to understand the context in which these kinds of conversations occur about structural racism and the experiences of our community. And what we really want to make sure that, is understood is that this is common, it is prevalent, it is ingrained in the way that we do things. So just thinking about interpersonal racism, that is extremely prevalent. So 90% of Black youth and adults report at least 5 incidences of racism daily, according to a lot of research. These experiences are oftentimes overt, or they can be subtle. They can be experienced directly or by witnessing others, have an experience. There are also racial microaggressions, which are brief, commonplace daily verbal, behavioral, or environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative racial slights and insults towards people of color. And this collective stress from racism can create chronic stress, which is linked to multiple psychological and physical outcomes. And Dr. David Williams at Harvard actually did research on the experience of everyday racism. And it's very clear that everyday little jabs, little sites, little things that you witness lead to health disparities and lead to worse health outcomes for Black Americans, which can include different disease, morbidity, and mortality as well. So, thinking about racism and how does it link to the work that we do in our communities. So racism is linked to health disparities. And health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged groups. So differences in disease outcomes due to societal norms or behaviors that should not be occurring. Structural racism is a fundamental cause of why these health disparities persist, even when focused interventions are implemented to address these disparities. So there is a lot of, different ways in healthcare that we try and address these health disparities, thinking about low birth weight within African American women. There's a lot of interventions geared towards addressing that, but those interventions often do not address the structural racism component that is contributing to that disparity. And so we really need to sometimes think upstream. And so kind of within the context of health disparities, we want to make sure that policy change is essential to addressing racial inequities and reducing health disparities. So when we think about health disparities, we also want to think about social determinants of health and kind of provide those definitions and an understanding as to the link between social determinants of health, racial and systemic inequality, and health disparities. So social determinants of health are conditions in the environment which people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. When we think about social determinants of health, there's typically a policy that's in place that leads to that inequity occurring. So when we look at economic stability, which is something that research has shown impacts overall health of an individual. There is a wealth gap between white and Black Americans. And there are fewer ways for Black Americans to accumulate generational wealth, like home ownership, because of systemic and structural policies that have been put in place. So for example, the Fair Housing Act of 1968 was designed to stop unfair housing practices, which prevented Black Americans from moving into certain neighborhoods. However, this act was rarely enforced after it was passed by Congress, which led to the Federal Housing Association giving 98% of loans for homes to white individuals for the vast majority of time that it was in place. Over time, this has changed, but thinking about since the civil rights movement for a long period of time, the Black community could not access loans to buy homes in different neighborhoods. So this led to less wealth, less ability to, move within from different SES settings. This also impacts access to jobs, benefits, being able to earn a living wage as well. Thinking about the neighborhood and the environment, That is also another social determinant. Where you live impacts your health. Neighborhood zoning. So areas that are racially diverse and have lower SES tend to be located closer to industrial plants and toxins. So the regulations for those communities are different than communities that are more affluent or that are predominantly white. There's different lead paint regulations oftentimes because those are controlled by the city. The enforcement can vary as well based on where you live. So residential segregation is a huge component of something that leads to inequality. If we eliminate housing segregation, so if we integrate our neighborhoods, it would lead to a complete erasing of inequities in education, income, and unemployment between Blacks and whites. And that's research done by Dr. Williams, again, at Harvard. So again, housing segregation is a huge component of what propagates racial inequities and is linked to structural racism and policies that are in place that do not allow for upward mobility. Thinking about education, we want to reflect on how our resources allocated to different school districts. That's based on the community you live in, your housing, your taxes go towards schools. When you live in a community that has homes that don't appraise as much, your taxes are going to be lower. There's going to be less income or less resources for those communities to be able to invest in their schools. There's often bias that teachers also have in students. Preschoolers are, Black preschool students are expelled at higher rates than white preschool students. Their behaviors are labeled differently. This has been shown consistently over different studies. And oftentimes, Black children have their behaviors labeled as deviant, disruptive, and that their white and other students do not have the same behaviors labeled the same way. We also want to acknowledge that within education, there's different access to resources. So oftentimes, based on the federal poverty line, families can access things like early on services for free and reduced cost daycare. However, oftentimes these programs are run by grants and they're time limited. So in different economic climates, those services may be cut. Different presidents may have different policies that they promote, and so those services may be cut. My mom worked on a grant within the Romulus School District for a long period of time, which provided aftercare, tutoring, community activities, big brothers, big sisters. And then, we went into the 2009 recession and all those programs were cut. So now that school district that was offering, this really great service for its students no longer had the resources to continue offering it. And so that program was cut and that service was no longer available to families. Whereas other communities may have resources that are invested in them. There are private daycares that are available. There are programs that are not dependent upon federal resources to continue. Thinking about the social and community context, how is money invested? Where are the resources going? Things like, is the community safe to take a walk in? Is there public transportation? Is there a sense of community? Do people feel like they belong to this neighborhood, to this group of people? Is there an identity? And oftentimes, neighborhoods of lower SES or neighborhoods that are more diverse, due to different factors, there's less of that community bonding that's available to kind of provide that support to individuals. And then finally, thinking about healthcare, there's also various factors that impact health outcomes. So Medicaid expansion is a huge one. So when the ACA was passed, states had the choice to expand Medicaid or not. And several Southern states chose to not expand Medicaid to individuals who were a certain percent above the poverty line. And so those communities now have many more individuals who are uninsured, unable to access healthcare, maybe presenting to the emergency room for healthcare rather than being able to seek preventative medicine. Oftentimes these communities have food deserts, but we label the behavior that they're lazy, that they're not driving to the grocery store, whereas recognizing that there may be a lot of structural barriers in place that prevent people from being able to access the same resources. Where hospitals were built is also a key part. Hospitals are typically built in high resource communities. Oftentimes people have to access community hospitals or rural hospitals in areas with lower SES and more diverse communities. And then I'm not sure the time period, but also at one point, the American Medical Association chose to close several Black colleges. And this was recently part of a American Psychiatric Association town hall. And they found that these Black medical schools that were closed as a decision by the American Medical Association has led to thousands of Black doctors that did not graduate or did not become doctors due to lack of access to schools. So another component of the inability to access resources due to where someone lives, the race they're born in. So while we do want to reflect that social determinants of health are very important, we also want to recognize that it's not necessarily the race part or the SES alone that is impacting those disparities from occurring. And this is a quote that I've come across in a couple of different settings, and I think it just really helps define this. I think we want to be careful about how we talk about race and poverty and other social factors, because technically they, especially race, are markers of health outcomes, but not the drivers of health outcomes. For example, being Black by itself does not cause poorer health. It is the systematic discrimination and racism that cause poor health outcomes. Without systematic discrimination and racism, we wouldn't have the large disparities between white and Black Americans. Same with poverty. Being poor by itself doesn't cause poor health outcomes, but not having sufficient resources to support good health is a driver. So we want to understand what the health disparities are in our community and what are the differences, and recognize that there is a multitude of factors that lead to them, but systematic racism is one of the key things that causes those disparities to occur and to persist, and that we need interventions on that level to be successful. So shifting to thinking about where do we go from here and what can we do? So I think many of us are in the role of being an ally, so being an important part of this work, promoting it, supporting it. And allyship is something that's come up a lot, and I came across this guide, which I think is really helpful because it provides some definitions. It provides, a way to engage and recognize why this work is so important. So we want to acknowledge that allyship is not just a word; it is an active process. It is something that you do every day to be an ally. You have to practice it. You have to really focus on yourself in every setting, recognizing the ways that structural racism is at play. So we recognize that, many of us cannot live the experiences of Black, Indigenous people of color, but you can stand by those individuals and you can help them bear the burden of their experiences. An ally might have more privilege, but they recognize this privilege and they're using their voices to help amplify and shine light on the experiences of oppressed individuals. So this slide just goes through some of the things that, when you are an ally, when you're trying to be in that space of helping support others, trying to break down these ongoing structures in our society that create racial inequities, we want to make sure that we are, that we're open to listen, that we're aware of our implicit biases. We're doing our research and we're learning about the history of the struggle in which you are participating. You do the inner work to figure out a way to acknowledge how you participate in oppressive systems. You do the outer work and figure out how to change the oppressive system. So it's this internal reflection and work on the external system as well. Use your privilege to amplify historically oppressed or suppressed voices. Do learn how to listen and accept criticism with grace, even if it's uncomfortable. And do the work every day to learn how to be a better ally. And we also want to acknowledge that sometimes it's hard to do this, and there's things that we want to be mindful of and that we don't want to be doing. So do not expect to be taught or shown. Take it upon yourself to use the tools around you to learn and answer your questions. Do not participate for the gold medal in the oppression Olympics. Everyone has their struggles, and so we kind of don't want to get caught up in that. Do not behave as though you know best. Don't trick credit for the labor of those who are marginalized and do the work before you step into the picture. And do not assume that every member of an underinvested community feels oppressed. So kind of allowing everyone's, asking the experience and asking for guidance and support, and willing to work together on this.
Okay, and then just sort of in terms of our work as DE&I committee leads in the Department of Psychiatry, we're sort of reflecting those levels of racism, now trying to figure out how we can meet those different levels. So allyship is very interpersonal, but it also is instrumental and really integral to doing the rest of the work and figuring out how to do this work. So in the spring of this year, after really just the surge in Black Lives Matter, the protests in the streets, and we felt that our department really needed to move on from this momentum, or use this momentum that was building in the community, in the country, and try and take a really hard look at our practices and our culture, and figure out a way to go forward and change things. And so we did what any large organization does. We put together a survey and put it out to the department. Our department is about 1,100 people. But we felt that it was important to not just start moving without hearing the voices of really those in the department that we represent as a committee. And so we worked through the responses of that survey and put together a strategic plan based on those responses, and are now starting to work on implementing that plan by really figuring out, these are the things that we can do on an individual or team level. These are the things that we need to work with the larger health system administration with. These are things that we need to work with community partners with, and sort of organize all of these actions into those spheres so that we can assign resources and really do this intelligently and effectively. Because there are certainly things that can be done fairly quickly and fairly painlessly, but there are certainly things that we need help. We need help from the community. We need help from Michigan medicine as a whole. And so that's where we're at in that process of figuring out what resources we need and moving forward. And our goals based on that survey are really can be sort of in very broad categorization of increasing access to mental health services for our community. Michigan medicine really doesn't only serve Washtenaw County, it serves a large area, the state of Michigan, parts of other states as well, because we are a large teaching hospital and research facility. We pull patients from a large area, but our day-to-day serving our community, really, we need to figure out, it's not so much how do we get someone from Indiana who needs specialized care. That tends to, we can figure out those things. It's really the more challenging aspect is day-to-day. How do we get someone from 2 miles away or 10 miles away, those last steps when, for instance, the bus system doesn't quite match up to where your resources are. So that's something that we can do in small ways in our own departments, but it's also something that we need to work with our community partners to work on. Increasing the number of providers who actually look like the community they serve. So this is a really challenging one because we now have a historical sort of flow of providers, doctors, nurses, social workers, medical assistants, et cetera, all who we haven't been doing a very good job in the last 30 years of recruiting and essentially making this a viable career path for people of color. And so now, how do we fix that? How do we get more folks into these professions so that when someone comes in our doors looking for mental health services, they feel like they're working with someone who looks like them, who maybe shares some experiences that they can communicate with, that they can connect with. And then finally, increasing the health system's awareness, particularly clinicians' awareness of how important a person's cultural identity and experience is when it comes to finding and utilizing care. So I think a very good example of this, and that one that's been in the news recently and probably for the next year, is the upcoming vaccine for COVID-19. There's a lot of information in the news about folks not feeling comfortable, not feeling confident in our healthcare system, and not being able to trust vaccines. And, you know, that leads to a lot of head scratching. But if you look at historical precedents for research for Black Americans being treated without their consent, or being research subjects without given consent, then you can begin to understand why someone doesn't trust our health system. But also sitting in a room as a therapist with a family and trying to work through how their cultural identity informs their willingness, their ability to engage in healthcare services. We need to know that so that we can be effective. It really, you know, it's not, we can have all the training in the world as to be excellent healthcare providers, but if we can't actually deliver that healthcare to a person because they don't trust us, because they don't think we understand them, or because we you know, suggest something that goes against what, you know, their belief system or their identity, you know, then we're not being effective. And so this means training our providers, focusing as much as we can on trainees, but also recognizing that we have folks who have been in the field for decades and years, and they also need this training as well. And so that is a large focus of our work right now. And then sort of back down to the interpersonal level, but also hopefully sort of filtering through the other levels of racism and the work that needs to be done, is what you, and as a member of this community, can do right now. The United Way issued this 21-day challenge in the spring, and it's still available on their website. It is an excellent, really structured approach to helping an individual, no matter what their experience is or their background, into engaging in these topics and really learning about the historical aspects of structural racism, the current effects of structural racism, and what we can do with our privilege, what we can do as allies, what we can do as members of the community, be it you know, on our team at work, in our families, what we teach our children. It's the list goes on. There's also Saima talked about allyship a few slides ago, and really just taking that as as recognizing that being informed and potentially getting some trainings. There are lots of local organizations that can help with this. Here in Ann Arbor, we have the ICPJ, the International Council for Peace and Justice, and they do trainings on anti-bias, or recognizing bias, on having difficult conversations. NAMI is another sort of mental health group that helps people in the community become connected with peer support and working to increase access to mental health care. And then, you know, it's really hard to not pay attention when we have a national election every 4 years or every 2 years for Congress. But really focusing and paying attention to our local elections and, you know, all those things down the ballot that can become overwhelming when you look at all the list of all the judges or the list of all the council member positions, and thinking about where your views and the views of those elected officials align, and paying attention, and perhaps even in volunteering with those candidates who you feel like would do work in these areas. Okay, and these are our references for the data that we presented tonight.
Thank you very much, David and Saima. We did solicit questions online, so if you're open to it, I'd like to ask you questions from our community members. You touched on this particularly at the end there, but the first question was about what mental health or public health strategies can we use to proactively dismantle structural racism and help prevent mental illness so we have fewer people harmed and less need for treatment to address harms and illnesses. So, I think you talked about trainings, educating ourselves, but more broadly, I guess, mental health and public health strategies.
So connecting with those organizations, as I said, but also being aware of the resources in our community, and what we know is helping people of color. This means being aware of what your local school board, like I said, those down ballot things are folks that we don't often pay as much attention to as Congress or presidential elections. But what is our school board currently doing to address structural racism? What is our city council? A big thing in Ann Arbor recently was housing, so fair housing. We see all of these large apartment complexes being built and condos being built in downtown Ann Arbor. And so what does that mean for those who can't afford to live in that space? And they may work in that space and they have to have a longer commute. And what does it mean what does that mean for our community, that we're really segregating that, even despite efforts in other areas that are just sort of stymied by this. And then use understanding intersectionality. So that's something that I feel like as a social worker, it was a really important part of my training in how everyone has so many different levels of experience and identity, and understanding where you fit in that, but also where those around you fit into that, and the experiences of other people seeking services. So what's the experience of someone in Ypsilanti trying to access mental health services versus someone in Ann Arbor? And going back to, again, figuring out where those points intersect and what we can do to address them. Simon, did you want to?
Yeah, so I think that's a good summary of, the focus on those interventions at a step back. So I think there's the interpersonal things that we do, like allyship. So being, recognizing every day we need to do this, but then also thinking about what are the systems that were in place, what are the policies within our organizations that we work, what are the things that we notice on a day-to-day basis, and how can we try and change those? And recognizing that a lot of this starts in childhood. So where are the ways, how can we invest money into early education, and recognizing that these effects begin sometimes in utero. And so we need to be more cognizant of those kinds of effects, and really thinking from a policy perspective, how can we support those kinds of efforts within healthcare, within the community. I think that's pretty key, and an important area of focus for public health.
So there's some sort of related questions so I might come back, but just because you were talking about sort of younger kids and schools. So there was a question about, as the pandemic accentuates socioeconomic differences and puts more distance between us, how can we reach the populations in need? So this was in the context of, the Depression Center works with schools throughout Washtenaw County. And I know some of our partners, particularly in underserved areas, are having a lot of issues with students not being able to attend class because of access issues, that sort of thing. So when so many students are receiving mental health care services in their school and they're not able to engage in school in the same ways in this virtual environment, how do we sort of address those things and make sure kids are getting access to services?
Yeah, I think it's one of the things that I've noticed as a therapist working one-on-one with kids and teens is that it's been a mixed bag in terms of moving to virtual care. So while it's tremendously helpful for someone I work with who lives an hour away to now, as long as they have a device, as long as they have a smartphone or a computer and internet access, they don't have to make that drive. They have more flexibility. They can perhaps see me weekly instead of bi-weekly. And that is a very positive thing. But we're also recognizing that it's really just amplifying those disparities because, for instance, in Ann Arbor Public Schools was able to give every student in the city, in the school district, a Chromebook. So they made sure that every student was able to attend classes through Zoom. There are plenty of other cities in Washtenaw or townships in Washtenaw County that were not able to do that in larger Michigan. So those kids are now falling further behind.
I think it's also thinking about how we can leverage some of the resources in our community. So as David said, one of the things that's key is that, hey, this is a secret tech, point. So how can we engage our community partners to help them want to invest these resources in our community as well? And in Detroit, there was a technology firm that did invest resources to ensure that every child had, or in a certain community that they had internet access. So it's kind of building those relationships, partnering with different agencies, and helping bring people together that have good ideas, the ideas and the resources and the capital, all those things that need to come together. Because it is really challenging to hear about these challenges that people can't get on the internet, their home, their parent has to work, they don't work in an industry that allows for, if they use the family FMLA, they may not have an income. There's a lot of these barriers that we're seeing now that didn't exist before. Though there are a lot of other creative solutions. So how can we partner maybe with churches to create safe spaces for students or for children to maybe go to be able to do school in a socially distanced, safe environment? And some communities are taking that on and kind of creating those spaces. So I think it's a group of people coming together to work on those things together. Our elected officials also need to kind of make sure that's a priority as well, because a lot of this is change that needs to occur on that level. And we need to, I think, as residents of a community, we need to make sure that our elected officials know that this is something that's important to us. So as much as, I hate getting on the phone after work, and making phone calls, I think that's something that is important is, calling your local official and saying, I'm really worried about, the students in our district who don't have access to technology. What are we doing? How are we going to help support them? Because that helps them know that that's a vote in their next election, a voter that's thinking about that outcome.
Yeah, that's great. And I know you talked about some of the challenges right there, but just in case you want to add anything, another question was, how has the shift to virtual affected access to services or the ability to extend care to populations in need? So it does sound like it has both benefits and sort of challenges.
Yeah, one that follow-up question sort of makes me think of is insurance coverage. And a lot of insurance companies back in March when quarantine was first instituted and we moved to virtual care, a lot of the private insurance companies switched over very quickly. And granted, some of them were sort of month to month where we would have to check with our billers, for instance, if a virtual appointment was covered. But then there were the Medicare and Medicaid service providers did not move so quickly. So they essentially, if someone at the beginning in March and April had one of the Medicaid providers that wasn't moving that quickly, that meant that they could not access care for 5-6 weeks until parity, I think political forces sort of moved the Medicaid providers to do that. But there was certainly some time where people were unable to access care because the insurance company just wouldn't pay for it. And the health system did, moved funds in some cases so that we could provide care. For instance, with our group therapies. and that's been a real bright spot. But the individual care has, I think, still been a little bit bumpy.
Okay, so the next question is, what has the University of Michigan done to deconstruct racism, and how difficult has that been during the pandemic? So I'm gonna assume that we'll be talking about Michigan Medicine. It's not clear if it's the university at large or Michigan Medicine, but.
So there are a lot of efforts across Michigan Medicine, the University of Michigan, and the state of Michigan, actually, to help, make this a priority. So I think it is amazing that Michigan Medicine and the university also acknowledge that Black Lives Matter is not a political statement, that it is a fact that Black lives in our society are not valued as much, and that they are often treated as, that there's not as much value placed on them, and that we need to be doing more to help address this disparity and to ensure that Black lives do matter, that we are not constantly flooded with images of Black people being murdered by the police, that they are worried about their well-being on a day-to-day, that they're worried about their loved ones. Just a trip to the grocery store could result, in then the loss of their life. So I think that is a huge step forward that, I would not have imagined this institution taking 10 years ago, but that doesn't mean that the work's done, because certainly saying something doesn't mean that there's action there. Though there have been several committees that have been formed. Rob Sellers is the Chief Diversity Officer for the university, who's been kind of spearheading a lot of efforts. And then on the Michigan Medicine side, Dr. Brown is leading several task force around health disparities and how to better how to address access to care here at Michigan Medicine, helping address the fact that our staff oftentimes don't look like the patients that we care for, and ensuring that interactions, that if Black or minorities that seek care here have negative interactions, that we're addressing that, and that we're addressing the bias that providers may hold. So I think there is a lot of movement occurring, and we do need to hold our the institution accountable, because they are a driving force. They're, the largest employer in Washtenaw County. They're one of the largest employers in the state of Michigan, and that if we lead the way, then that can help create change across the state.
Yeah, I think one other sort of cultural shift that I've really appreciated is that it is widely communicated now by our leaders that it is not enough to just not be racist, and that it is our imperative to be engaged in anti-racist work. And so I think for a lot of folks in the past, whether it's privilege or just compartmentalization, or sometimes you just have to focus on your own stuff. But it basically, when you think of it as in that black and white term of I'm either not a racist or I'm a racist, then that means if I'm not a racist, I don't really have to do anything. I'm good. And now our culture has shifted toward in U of M and Michigan Medicine to really push that forward, that it requires some action, it requires some change, it requires a stance, and being not racist is not good enough. We have to actually be working against these forces. So I think that's one of the things that I've been really just heartened by, working for this organization, and sort of hopeful that we really take that leaders and best adage to heart and really lead by example.
I think I'll just add to that too. I think a lot of personal journey and change that's occurred, over the last, 8 months of this pandemic in particular, because I think there's so many factors that led us to focus on these racial inequities, that COVID really amplified them, and then the very visible, deaths that occurred. And so I think there's also a lot of movement to changing the language that we use, as David said, kind of the anti-racism, but then also being able to reflect on our own racial identities. And I think the work around white privilege and being able to recognize that We all carry privilege. There's different things that, you know, each of us has, there's different experiences, but that we do need to deconstruct that privilege that occurs just by being white and being in a society where your norms are the norms of the society. And I've heard a lot more conversations about that, and people doing a lot more of their own individual work to process that experience and those experiences, and to be able to kind of really shift from being in that colorblind space where you kind of, the way I was raised is that, oh, we want to be a colorblind society. We don't see race, everyone's treated equal, and really being able to now acknowledge, nope, as human beings, we can't do that. That is in our mind, that when we see differences, we're going to assign value to those differences. And those values are often based on biases that we hold because of the society that we live in. And so that active movement to be able to acknowledge those biases and change them, I think is really positive.
Thank you. So now we have a question, it sounds like from the patient perspective. So the question was, is there something that those fortunate enough to be receiving mental health care services like me could do to contribute to a reduction in structural racism in the field? It is understood that there are times when personal circumstances or mental status might make this impractical, but when able, what concrete steps could patients take to forward this objective? One might say this could be an effective way of giving back as well as paying it forward.
So I think one way that comes to mind is being, if you are able to participate as an advocate in our health system. We have programs for, I think it's the PFCC, so patient and family centered care, which is a group comprised of patients that inform policy and action in our health system. It requires volunteering your time and your resources, but that is certainly one way that you could do that. Simon, did you have?
Yeah, so I think being an advocate, I think, is a key thing, and to, be in a space where we're creating conversations, because I think part of what people can do who have themselves been through mental illness is kind of share their stories, which can help reduce stigma and help other people feel more comfortable seeking care. So I think that's, it can be hard when you're in the midst of kind of mental illness, but I think recognizing that giving back component can help you as well move forward and be able to help others. And then I think also just in an everyday, just thinking, what can I do? It's being anti-racist and kind of really being thoughtful about your actions and really actively being engaged in that, reflecting on the work that you're doing, reflecting on who's in the room. If you are in an advocacy setting, who's there, who's not there? Is there more that we could do to engage people that are not in the room? Is there a setting that would be more welcoming to people who are diverse? Is there language that we're using that isn't welcoming? So I think those are the things that, if you feel comfortable maybe bringing up to someone in an advocacy setting. I think advocacy is key. Like, if we can have more conversations about mental health and then have them in diverse settings, that can hopefully help more people.
Thank you. So now I have a question for college students. So it says, is there anything disability services offices can do to support college students with the topic of structural racism and mental health? Any resources we should be looking at and including for students?
So I think I reflect on intersectionality for this as well. So kind of, if you work in disability services, that's a wide array of services, but oftentimes mental health falls within that spectrum as well. And recognizing that your Black students who are coming in to seek services have a very different experience than the white students. And normalizing seeking care, supportive services, thinking about the space that your clinic is set up in, or in the Zoom environment, are there ways to make it more friendly or welcoming to people who are non-white? So for clinics, thinking about magazines, wall art, all those things really do make a huge impact on whether people feel welcome to a space. So I think in college settings, I think mental health services are often underutilized by minority students, or disability services are underutilized, or they've often never been afforded, they've never been diagnosed with something that would allow them to obtain those resources and support. So being aware of that as well. So providing education, I think getting out onto the campus, ensuring people are aware of what resources are out there. If you struggle, are there supports that you can access to ensure that you can be successful in this setting? Because if we look at rates of college graduation rates, there is a huge disparity between Black and white students, even here at the University of Michigan. So we do need to be doing more to help support our students of color.
And the last question that we have here too is, you talked about the need to diversify the mental health field. Do you have ideas about how we go about doing that?
One thing that, medical schools and training programs are, I think, one avenue. When I think of sort of the area that I know best as a social worker, just as I think a really good example of this is that for many years, the Michigan Medicine has a very large internship program for master's level social workers. To enter the field, you have to complete a year-long internship. And one of the known through the U of M School of Social Work, like the best opportunity if you want to do medical social work or be trained in psychotherapy for that year is through the Michigan Medicine internship program. And this just sets up, in the past, it was set up to cater specifically to U of M students. So it set up this pipeline of predominantly white students going into this internship program, and then you're developing professional contacts that are going to be beneficial for the rest of your life. You have a better chance of getting a job upon graduation. And so what they've done in the last few years is open that internship program up to other schools of social work, Eastern Michigan, Wayne State, and a couple others, I think, University of Toledo. But what that does is that again diversifies that incoming flow, so that we now have more opportunities for students from those universities and colleges to develop those same professional connections and start to make the makeup of our clinical workforce look different and look more reflective of the community in which we serve.
I think there's
I was not aware of that. That's very cool.
Yeah, there's all these kinds of systems, right?
Yeah.
I think there's a lot of initiatives to kind of think about like a pipeline, like how do people get into different fields and how do they engage interest? How do we get people? And so it is thinking about taking that step back. How do we engage? I think students that aren't going into the sciences occurs like in middle school, that gap between boys and girls interest in different fields occurs at that age. Black students are often told you're not going to be, that's not a career you can have. Why are you thinking about that? There's a really funny video of the astrophysicist, and he talks about how he was repeatedly told, this isn't a job for you. And he said, it was my perseverance. It was the fact that I knew when I was like 6 years old, this is what I want to do with my life. But so many people are told repeatedly, this isn't the career for you, this isn't the path for you. And so they do not enter that field. So we need to be really looking at the messages that we're sending to elementary students, to middle school students about what are the careers that they can access and what is a career path that they can pursue. And then I know that there's a lot of hiring initiatives within Michigan Medicine and the university as well to recognize that our hiring practices are oftentimes really only looking at a select group. So oftentimes people that come to our faculty or that are physicians here at the university know someone. So they have a colleague and they said, hey, come to Michigan Medicine, it's a great place to work. So if our staff is mostly white, they are going to be recruiting other white providers. So recognizing that we need to be doing more to attract diverse providers to our institution. Mentored people of color within the health system within the university as well, so that they feel like they are a part of the university, that others support them, that their experiences are valued. And I think that they have a place where they can grow as well, their careers. Oftentimes, Black and minority providers, staff just feel like there are no role models, no people that they can go to talk about their experiences. So I think really emphasizing on that aspect, that social support, creating a sense of belonging is really important to help diversify the workforce and help create systems that better serve the communities that they, I think right now we can definitely reflect that our care system does not look like the community we serve, and we need to be doing more to address that.
Well, thank you. Those were all of the community questions we got. Was there anything else you'd like to add in closing?
So I think just reflecting that, for David and I both, I know we continue this work. This is something that, we both are passionate about. We are constantly learning, trying to evolve further within, the diversity, equity, inclusion lens and framework. So that's kind of one thing to just kind of comment on.
Yeah, I would echo that. This, the quote that Sima read, that I think that was like one of the biggest aha moments for me, and why I feel like is a motivator for me to be involved in this work as much as I can, because there are all these things that the assumptions that we make based on our environment growing up and moving through our education, and things that we take for granted, and like the idea that Black Americans have higher rates of heart disease. I don't know, it's not like this was a daily concern of in my thought process, but I just assumed that was like how it's always presented, is that it's a biological difference, but it's not. It's something that we can actually affect. We can do something about it, because it's that structural racism, and it's the structures that it is so prevalent in our country, in our society, and it can feel very overwhelming very quickly if you sort of let your mind go that way. But if you can really focus on the individual acts that you can take, and the actions and the education and the advocacy, then I think it really it feels doable and changeable.
I think recognizing we need to do this work, unfortunately the change can't happen overnight, but that if we really are committed to it, and we slowly do these things every day, we can dismantle these structures.
Well, I want to thank you both for your time today and for your continued work, both as the DEI co-chairs, Michigan Medicine, Department of Psychiatry, and then also your work with the community. I appreciate all that you do and all the work moving forward. I appreciate it. Thank you.
Thank you.